Do it.
Okay. Well, welcome everyone. Thanks for joining us. My name is Lindsay Martin, and I am the VP of Consulting here at RxTrail. And joining me today is Bailey Hall, who leads our compliance and regulations efforts. Between the two of us, we have seen it all. We spend our days working directly with covered entities across the country, helping them navigate the ever-changing 340B landscape. So before we jump into this, I just want to thank everyone for questions submitted. It was an overwhelming response, and that just tells us how uncertain and how much things are changing and all the things we're dealing with right now. So the good news is there were some very clear themes. Nearly every single question had something to do with manufacturers, ESP, claims, rebate, IRA. How do we prepare? What are we doing? So I don't think there was a single response that didn't have that topic selected. So we took all of those and we're going to try to address as many as we can today. Let me go ahead and, here we are. Go to the next slide. So because of that, we structured today's webinar around those themes. We'll start off with the manufacturer updates and policy trends, spend some time discussing the rebate model and what we're seeing there, wrap up with IRA, and then kind of like, how do you prepare for all of this? So for those of you that submitted questions related to HRSA audits, because we did also get several of those, compliance and audit readiness, don't worry, we saw those too. And there were enough questions on that topic that we have already got it on the books to do a webinar next month for just HRSA audit readiness and to answer some of those more nitty-gritty compliance questions. So with that, I'm going to turn things over to Bailey, who's going to kick us off with our first question.
Yeah, thanks. So we'll start with our first topic. It's kind of all about the latest manufacturer updates. So our first question, what manufacturer policy trends are we currently seeing? And if you want to go, yeah, there you go. So there are two main trends we have been seeing over the last few months from the manufacturers. Those are expanded claims data requirements. So several manufacturers are expanding their policies to not only require contract pharmacy data as a requirement to accessing 340B pricing, but now they're also including in-house pharmacy or entity-owned pharmacy claims data and medical claims data, which would be like your hospital or clinic administered drugs. The second side of that, the other trend we're seeing is a shift to the platform called Truzo rather than ESP. So we're going to get more into both of these two trends in the next couple slides.
Okay.
Click on over.
I'm trying. There we go.
Okay, so we're going to start with the increased data requirements. I'm going to talk about who's affected, what manufacturers this applies to, and how it's kind of impacting covered entities right now. So the manufacturers currently requiring in-house pharmacy and medical claims data are Exelixis, Eli Lilly, Novo, AstraZeneca, Bristol Myers, Biogen, UCB, and Amgen. These manufacturer policies have pretty much all been rolled out just in the last couple of months. So I think it's reasonable to expect that we could see additional manufacturers follow this trend over the next couple of months. Some changes that we've seen and just kind of how things are impacting entities so far. So some TPAs do not have like really sufficient reporting or submission capabilities to facilitate these new requirements. We're seeing that some TPAs may require entities to update their like certain feeds with their TPAs to be able to access all of the required medical claims data. We've got some entities that don't use a TPA for medical claims at all, which adds an extra layer of complexity and just work on the entity's end to be able to produce that data without having a pre-built report just available to you in your TPA. Another kind of trend we've seen over the last couple of years with these expanding manufacturer requirements is that some covered entities have implemented alternative distribution models or ADMs to kind of offset some of the lost revenue because of those restrictions. So covered entities that are operating ADMs right now are making the choice on if they're going to exclude these manufacturers from their ADM procedures because of these new claims requirements. So if they are doing that, that's certainly impacting their 340B revenue that's associated with their ADM processes. And obviously that will just continue to have even more of an impact the more manufacturers join this trend. Another note I kind of want to point out on this slide while we're talking about the increased claims data requirements is the latest from the manufacturer Amgen. So in their latest policy that they released where they announced their in-house pharmacy and medical claims requirements, they also said that effective November 15th, they are going to start seeking healthcare visit and service claims data. The notice said that the new data would include information about interactions between providers and patients, resulting in that 340B dispense. They don't have any specific details or like the exact data fields that will be required for this, but they did say that more information will become available prior to that November 15th start date. If this happens, they will be the first manufacturer to ask for this type of data through ESP, and that could spark a whole new trend of manufacturer policy shifts if they decide to follow in Amgen's footsteps. So more to come on that, and we will see what happens. This table here just shows all of those manufacturers I had mentioned that have started in-house pharmacy and medical claims data requirements. We've got their effective dates and then any state exemptions. I will point out just on this slide that these policies mostly apply to all covered entity types that have in-house pharmacies and medical claims data, with the only exemptions really at this point being at the state level. And then here we've got just a look at what is actually required for the medical claims through ESP. The in-house pharmacy claims data requirements are the same as your contract pharmacy claims data requirements. So same fields that you're already submitting for your contract pharmacies to ESP, you're just now going to do it for your in-house or entity-owned pharmacies too. The medical claims is where it gets a little bit different. We've got some different fields here, so just wanted to kind of point these out. These were kind of the same fields that Beacon was going to require at the end of last year when we were prepping for the Beacon 340B rebates. So these might not be totally unfamiliar to you, but just so you guys can see. One note on this slide too, I always like to point out is most of these are required. The HCPCS code and the unit of measure are a little bit different, and one or the other is required, but not both. So, okay. Then shifting over to the other trend that we have seen lately is manufacturers moving to the platform Truzo. So Truzo is a new platform that manufacturers are choosing to implement their pharmacy designation and claims submission policies through. It functions similar to ESP, but they are two completely separate platforms. So some manufacturers who were already established with ESP and operating through that platform have changed and moved their stuff over to Truzo instead. So those include Alkermes, Organon, and Gilead. There are a couple of manufacturers too that did not have contract pharmacy restrictions in place at all and are basically starting fresh with Truzo, which are Amphastar, Argenex, and Puma. So this shift has also created its own set of challenges for covered entities. Aside from the obvious burden of now having to manage multiple platforms for essentially the same purpose, we are seeing that there was a pretty significant gap in TPA readiness. Not aware of any TPAs that are currently integrated with Truzo to be able to submit claims data on entities' behalf. Several of them do have reports that they've created for you to download and submit yourself. And the pharmacy claims data requirements for Truzo are essentially the same as ESP, but it's navigating which claims you're submitting on which platform. And then I just want to point out too that Truzo does have the capability of accepting medical claims data, but at this point, none of the manufacturers that are implemented on Truzo are requiring that. So it may be a possibility in the future, and they're ready to go if it is, if more manufacturers move over to the platform or the manufacturers that are there do start requiring medical claims data. So could see that in the future as well.
Awesome. Okay, are we having fun yet? Let's do a poll. We have our first poll. We're going to try this out and see if it works. So it should pop up on your screen. Who is currently submitting in-house claims? Are you submitting in-house, medical, both, neither? So go ahead and vote. I'll give it just a minute. So we'll get some responses in and then I can share the results. This is always interesting to me. I think it's good to know what everybody's doing. Oh, we got some votes coming in. Okay. Give it a couple more seconds. Okay. I will publish the results. You should be able to see those now on your screen. We've got, okay, about 40% that are submitting both. In-house, 30%. Okay, this is interesting. All right. Hopefully you guys find that interesting too, just knowing kind of what's going on. Also, just a quick reminder before we keep moving on, if you do have questions that come up as we're going through this, we do have it like the Q&A section. You should be able to type in a question. Nobody can see your name. So just if you want to type something in, nobody sees it unless we publish the question. But we can also follow up after if you have additional things you want us to follow up with. So just want to make that mention as well. Okay. So moving to our next question. So should you be submitting in-house pharmacy and medical claims data? So this is kind of one of those decisions that you're going to make with your entity. Encourage you to, talk to your legal counsel, compliance, and consulting teams. What I can tell you is that to date, we have not seen a manufacturer actually remove the 340B pricing because an entity has declined submitting to in-house pharmacies or their medical claims. However, in addition to Lily, who has sent out emails to certain entities that haven't been participating, asking for meetings because they want to grill you and ask you what you're doing and why aren't you doing it. As of yesterday, they sent out letters and announced that certain covered entities have been given 5 days to comply with its claims data requirements, or they risk losing their in-house or medical 340B pricing. So whether that ultimately results in pricing being pulled remains to be seen. So the other piece of this is just the operational burden. So for a lot of hospitals, this isn't just like clicking a button and you send a report. Like these reports don't even exist today for most entities. So they have to be built and validated and maintained. And that's resources and cost, and just needs to be considered as part of the decision when you're deciding how to move forward with these. One thing that did come up, we attended the 340B grantee conference last week, and they were talking about the in-house and medical claims data submissions. And there was an attorney there who in the session made very clear, cautioned every entity, if you get this email from Lily saying that you need to meet us and tell us why you're not submitting and all of that. He just said anything discussed or shared on those can be used against you later, basically, not against you, but used later. So it's important to understand why you're meeting with them and who actually should be involved in those discussions, and does your own legal need to be present for those discussions, et cetera. At the end of the day, every covered entity really has to decide their level of risk and what they're comfortable with. Some are submitting. Sorry, this little dinging. I'm really sorry, guys. The chat is dinging, and I don't know if you guys can hear it, but okay. So basically, some entities are submitting to just comply because they don't want to test the limits of the policies, and some are choosing to basically not submit because there's nowhere explicitly required under the 340B statute, and they're choosing to push back. So I think the bigger question really is what happens next. Will Lily follow through? Will HRSA respond? Will there be legal challenges? We just don't know yet. So my recommendation just stays the same. Document your decision making, involve legal counsel, understand your operational burden, and just monitor things closely, and just make an intentional decision. There's not a right or wrong answer at this moment because we don't really have all of the answers. Moving on to next question, how should covered entities adapt their pharmacy strategies and workflows? So we're really seeing covered entities adapt into areas, pharmacy strategy, and then operational workflows. So from a pharmacy strategy perspective, a lot of organizations are taking a step back and asking whether, the current contract pharmacy network that you're utilizing still makes sense. Because in some cases, it really doesn't, and you're losing more money by staying contracted with them. We're seeing covered entities look at, whether how they can maximize those current manufacturer restrictions. Like, do all of them need to be at one pharmacy? Does it make sense to have, multiple designations? For grantees specifically, there's a unique opportunity there that you can leverage, like unlike hospital entity types that are, limited to single pharmacy. Grantees can designate one contract pharmacy under each individual 340B ID. So if that's not something that you're doing as a grantee, that gives you some additional flexibility when you're thinking through that pharmacy network strategy and all of these restrictions. On the workflow side, honestly, I'm sure you guys feel it too. This has become a full-time job, maybe 5 people job. I'm not really sure. But you guys are trying to manage keeping up with manufacturers, figuring out who's excluded, manage your TPAs, adjust, your processes every time there's a new policy. And then there's, the data side of it, trying to develop these reports and how do you access the data. And this is all stuff that didn't exist a few years ago. So it's a lot. So what started as kind of like a contract pharmacy issue has really turned into a much bigger program management issue. It's impacting so many layers, and CEs that seem to be navigating it the best are the ones that have stopped treating like each manufacturer policy as like a one-off issue, and instead have developed just that overall strategy of how they're going to respond to restrictions moving forward. Having that plan of tackling as these come in is key. And that's kind of what we do with our customers on a daily basis. So if you need assistance with that, like how are we going to manage this? Who should be doing what? Please reach out because we would love to help you develop that. Bailey.
All right, I'm going to take us into our next topic and set of questions, which is about the 340B rebate model. We just had some big news come out about this last week. So first off, I'm just going to start by answering what is the current status of the 340B rebate model. And to do that, I'm going to give you a brief summary of kind of how we got to this point over the last couple of years.
Oh, there we go.
Okay, so just to summarize, back in 2024, there were a couple manufacturers who tried to implement a rebate model just on their own without HRSA involvement. HRSA did come in and stop that and said that HRSA had to pre-approve any rebate models before they were implemented. Then last summer, HRSA came out with their own 340B rebate model pilot. This was set to cover the first 10 drugs selected under the IRA and was to begin January 1st of this year. HRSA eventually approved all of the manufacturers' policies that were involved in that pilot of the selected drugs. But then right at the last minute, before it was set to go live in January, we had the courts block it on like December 29th. So just in the nick of time, the courts ruled that HRSA had actually bypassed certain rulemaking procedures that are required under the Administrative Procedures Act. So HRSA decided to essentially scrap that rebate model. They threw it out and started over from the beginning about a month later. So in February, they announced opened up a request for information, which was basically seeking public comment on the impacts of a 340B rebate model. That comment period was open for a couple of months. And then just last week on May 27th, we learned that HRSA submitted its new rebate model proposal to the Office of Management and Budget, or the OMB. So this officially enters us into the pre-rule stage. At this point, we don't have any details on what exactly that proposal entails. So what drugs it will cover this time, if it will be all entity types, if it will be pharmacy and medical claims, when it will start. We don't have any of the published details yet, but I'm going to kind of get into what we can expect next. So what happens next in the rulemaking process? This timeline can definitely vary. This is kind of just an estimate based on how long this process typically takes and what we've seen in the past. So where things sit right now, the OMB has the proposal. They're reviewing that to evaluate its economic impact. During this time, certain stakeholder groups may request meetings with the OMB to basically make their positions heard. In all, this OMB review period can typically last anywhere from 30 to 90 days. Then once the OMB clears the pre-rule, HRSA would publish this proposal in the Federal Register as a notice of proposed rulemaking. At this point is when we would get the actual details of the rebate model and what it's going to look like this time around. And that's usually also when HRSA would open another public comment period for people to give feedback on like the specifics now that we know the details of the rebate model. So this will likely come mid to late summer, and then that comment period, that second comment period, will probably be open for another 30 to 60 days, meaning it's likely that that HRSA will publish their final rule sometime this fall. And what we know from last year is that HRSA had stated that covered entities are to get a 90-day notice before any rebate models are started or implemented. So following that logic and kind of the timeline that we saw last year, I think it's pretty reasonable to expect that if this moves forward, we're looking at probably a January 1st start date again for 2027. Again, just an estimate, but kind of based on how we went through this in the past, I think that is likely where we are headed now. So.
Awesome information, Bailey. Thank you. Okay, so what happened if you're like me, you're like, okay, so what happened with the, HRSA RFI comment period? I always find this extremely interesting. So we wanted to share it with you guys as well, because I'm sure a lot of you submitted your comments for this. So this request for information generated an incredible response from the 340B community. HRSA actually received over 5,500 comments, which is believed to be the largest response they've ever received on a 340B related issue. What's interesting is that only 2,500 of those comments were made publicly available for review. So that means more than half of the submissions were not available for public analysis. So any conclusions being drawn today are based on the portion that obviously we could see. One thing that stood out with the publicly available comments were the number of duplicate template-based comments supporting the rebate model. There was roughly like 1,200 of them that were tied to Patients Rising, which is an organization that has received pharmaceutical industry funding. So those submissions came through in alphabetical order, contained all the same language, making it very clear that they were a part of a coordinated comment campaign rather than independently drafted responses. So, take that for however you want. Okay, changing the slide to this one. Based on the analysis that has been done on the publicly available comments, the message was pretty clear. Of roughly 2,500 comments available, about 13 are actually legitimate, unique submissions by entities. Of those, about 94% opposed, 5% supported, and 1% were unclear. Whether, HRSA ultimately gives those comments the same weight as like unique submissions is something we don't know as far as, the Patient Rising ones. However, even after accounting for the coordinated submissions, opposition to the rebate model is like overwhelming. So for me, the biggest takeaway with all of this is that HRSA has a very clear record showing widespread concern about the rebate model. The comments raised concern around all the things that I'm sure you guys have stressed: cash flow, administrative burden, operational feasibility, compliance challenges, just the overall impact to your patients that you serve. So the big question now is, what will HRSA do with this information? Obviously, we haven't seen any indication what's next. But if it's expanded, they can't ignore what's right in front of them. So at a minimum, HRSA asked for feedback, and the 340B community showed up in a very big way, which is pretty awesome. So next question: how should covered entities prepare for a potential rebate model now? So even though we don't know exactly what the final model will look like, kind of based on what we've went through, we know sort of how we can prepare. First, just understanding the potential financial impact on your organization. So that means looking at the cash flow implications and understanding your exposure to those IRA negotiated drugs, both in 2026, but even more so in the 2027 list. So every entity's profile is going to be different. And this is something that we've done for each of our customers, and we will do it again when we have a better idea of what that final ruling is. But second, just start planning now for like how the claims are going to be submitted if it moves forward, both be prepared for both pharmacy and medical. Talk with your TPA about what they can provide, what's available now, what gaps, like be pushing for some of those things to make sure that they're available. Make sure everyone understands their role within your organization is key. So just thinking about operational workflows, if a rebate model is implemented, this really becomes reimbursement and rebate process rather than, point of sale discount process. And in most of these proposed models, the faster you get your claim submitted, the faster your rebates are paid. And, we're going to talk more about kind of what's happening with current rebates with MFP in a little bit, but just don't underestimate the ongoing work that's going to be required after claims are submitted. You're not like just, okay, got it submitted, done. So someone will need to be responsible for monitoring rebate payments, reconciling what's been submitted, what's been paid, identifying the missed rebates. That reconciliation process is going to end up being just as important, if not more important, than the submission process itself, which we'll go into in the next section. But my biggest recommendation is don't wait until a rebate model is finalized to start asking these questions. The CEs that are preparing now are going to be in a much better position if and when these models expand. So, okay, we've got another poll for you. Let me get over here. If the rebate goes through, how prepared do you feel? Fully prepared, mostly prepared, somewhat not prepared at all? These are kind of fun because I can't see you guys. So it's fun to at least know that. Okay, we're getting good responses. Okay, let me publish the results. So, the great majority is falling in the bottom half, and I get it. I totally get that. So we can collectively all feel you're not alone in this at all. Bailey's going to kind of go into a little bit more of just processes and more, preparation.
Yeah, we're going to shift gears a little bit to what is currently going on with the Inflation Reduction Act and maximum fair price rebates, which sheds a little bit of light on how rebates are working right now, how that might translate over into a 340B rebate. So I'm going to start with how is the IRA affecting covered entities right now. We're going to talk about this in kind of two separate categories that just have some different considerations. First, how is the IRA impacting covered entities through their in-house pharmacies? And then how is the IRA impacting covered entities at their contract pharmacies? Some entities might have both of these, some may just be one or the other. So just a little bit different how it's impacting your entity specifically. So starting with the covered entities that do have in-house pharmacies, what you're going to see is you're now having smaller 340B margins on the IRA drugs. Under the IRA, Medicare began reimbursing at the maximum fair price rate for those 10 selected drugs, which is much lower than historical reimbursement rates. So this is going to shrink the spread between your reimbursement and your 340B acquisition cost, just overall reducing your 340B revenue on those drugs. The other revenue impact that you're seeing likely is that there have been inconsistent MFP rebate approvals, leading to revenue loss on your non-340B claims also. So if you're purchasing a drug on a non-340B account, you're only reimbursed at that MFP price, which is going to be lower than what you paid for the drug. And then you don't get that MFP rebate back in, you're now at a loss on that claim. So we have seen this has been quite a big problem across the industry. There have been reports of inconsistent MFP rebate approvals, with it's being reported that 40% of MFP rebates that should have been eligible have not been paid out to this point. There's been unclear denials, ineffective appeals processes, and I think it's just very apparent that the MFP rebate process requires significant oversight and tracking, which obviously creates a huge administrative burden on covered entities with the in-house pharmacies. On the contract pharmacy side, it's a little bit different, but some themes are the same. So your main revenue hit is going to come from that same smaller 340B margin due to the lower Medicare reimbursements. Another factor that is further reducing 340B revenue on the contract pharmacy side is that we're seeing that certain pharmacies are choosing to completely exclude these IRA drugs, either from 340B altogether or from 340B if there's a Medicare payer present. So this completely eliminates any 340B revenue you might make through your contract pharmacy on those drugs. And this is kind of a challenging situation because what we've seen is that this is a decision being made by the pharmacies and not really with input from the covered entities, especially for the larger chain pharmacies. You as the covered entity also don't have access to their MFP platform to help with identifying 340B claims or see what's going on, anything like that. We have heard reports that even pharmacies that have blocked the IRA drugs altogether are still having their MFP rebates denied. We've seen or heard that even pharmacies who have never been associated with 340B at all are also having their MFP rebates denied on the basis of it being a 340B claim. So just a lot of missed rebate payments here is kind of the takeaway. So if your contract pharmacies are excluding these drugs, I think it's worth having a conversation with them, seeing if there's any way that they're willing to work with you to include those drugs again, to kind of maximize your 340B revenue and benefits to both you as the entity and them as the contract pharmacy. So overall kind of takeaway here, I think it's important to point out that the MFP rebate process as a whole has had a huge impact financially and like in the workload that it is taking to manage this. Kind of how we talked about is kind of going to be similar with the 340B rebate and what's required of you for that. Another factor to this is that this is only for the first 10 drugs and we're only talking about one payer here. So not to be negative, but this kind of highlights how much more complicated it could get once we start adding additional drugs in as they get added over the years with the IRA. And once we start adding additional payers if we're talking in terms of a 340B rebate model. So lots to consider. It's kind of a little bit of a scary preview as to how rebate models operate. Okay, we're going to move along to how you should handle MFP rebate reconciliation. And I will kind of note that this is more focused on the covered entities that have in-house pharmacies, or if you're here from a pharmacy, just a pharmacy perspective. But as a covered entity with only contract pharmacies, you would not be the ones that are handling any of this MFP reconciliation and stuff like that. So just kind of wanted to make that clear. We know, obviously, this is a very labor intensive and complex process, and there's been lots of issues so far, but I'll kind of walk through some of the suggestions that are out there and kind of what you can do. So if you have not already done so, hopefully most people probably have, but enroll in the Beacon MFP platform. This platform is not required, but you'll see it's pretty crucial for managing this process. So definitely want to make sure you're registered in that platform and learning how to use it. So there are some ways of voluntarily identifying claims as 340B within that Beacon MFP platform. This can be done manually, either by, like there's a button you can click in the platform to identify a claim as 340B, and that can be done at just an individual claim level. Or if it applies to you, you could mark the entire pharmacy as 340B only. You would obviously only do this if you're like a closed door pharmacy that's only ever dispensing the 340B patients. Another route you could choose to take for 340B identification is to utilize claim modifiers such as the submission clarification code 20. The dispensing entities can voluntarily apply these indicators to a Part D claim to signal that it's being billed for a 340B drug. I think it's also important to point out that it is important to submit good clean data to ESP as well. We know that Beacon, MFP, and the manufacturers are relying on that ESP dispense data to identify 340B claims throughout this MFP process. All right. And then if they were to deny your MFP rebate, saying that it was a 340B claim, you know it's not. This is kind of how you would go about handling that. So you can open good faith inquiries through the Beacon MFP platform, which is why it's crucial to be enrolled in that if you're not already. If they have, there's different reasons you can start GFIs. You would select this isn't 340B reason for this example. You can find your individual claim, click create a new inquiry. You'll tell them it wasn't 340B. Beacon will give you a particular wholesaler invoice number. Then the covered entity will need to go to ESP and upload all of the 340B claims that make up that invoice number to prove that that claim was not 340B that was in question. So this also just kind of want to point out that ESP and Beacon MFP are completely separate platforms, but we know that they are working together on this process. So just further makes it even more complex that you're having to worry about so many different, platforms throughout this process.
Yeah. Before we go into this next poll, I just want to say this is also like how things should work. Like in a perfect world, this is how it's supposed to be working as well. Like obviously we're seeing that it's not working the way that it was intended. So, these things are taking a lot of time to manage. So that's all I wanted to say. Like it's not going seamlessly as they're wanting it to go. So, or saying they want it to go, I guess. Okay, last poll that we have, I will go ahead and start that. If you have an in-house pharmacy, what percentage of the rebates have you been paid? 100%, which would be beautiful. 75, 50, or you have no idea. I don't know how many people on here we have that have an in-house, so I'm not sure how many responses we'll get, but got a couple more coming in. Oh, somebody said 100%. Okay, I will publish the results. So again, as you can see, there's a lot missing, a lot of rebates missing. And that's unfortunately what's going on right now, which kind of goes back to the beginning of we've got to be prepared as much as possible, and also using our voices as much as possible. Let me hide these real quick so it goes off the screen. Okay. What should covered entities expect for the future IRA drug additions? So here we have it, folks. So the biggest thing covered entities need to understand is that the impact is expected to grow significantly in 2027. So if you look at the 2026 negotiated drugs, about like 80% are profitable. And then that flips dramatically when you look at the 2027 drug list, that only about 35% are profitable. That's why we're continuing to tell covered entities and working with our customers to focus not solely on that 2026 list, but we need to be starting to plan for this financial impact for 2027. Let me go to this next slide here. So it's also important to remember that some of the 2026 drugs are expected to exit the program as like generics or biosimilar competition enters the market. So currently, that includes, let me look here, Entresto, Novolog, Fiasp, Stelara, and Xarelto. So as these drugs fall off, they'll be replaced by additional negotiated drugs that may have a different financial impact on your program. So our recommendation is please start analyzing this utilization now. What drugs are you dispensing? How much of an impact are you going to have? What's the plan for when this starts shrinking or those margins, disappear? I can't emphasize that enough. And this isn't obviously, like I said, a one-year conversation. Beginning in 2028, the Medicare Part B drugs become eligible for negotiation as well. So for many covered entities, that's going to create a larger impact because it's going beyond pharmacy side and into your medical benefit side of the program. The CEs that are preparing now are looking at this as a multi-year strategy rather than just a single drug list. So understanding your exposure is going to be critical. And here at RxTrail Bailey Knight, like this is something we continue to do for our customers and are happy to assist in just evaluating your program and setting up a plan. So please reach out if you need assistance with this, because I feel like we're just throwing up a lot of bad news at you guys. And I don't like that, but hopefully it's informative. So before we sort of kind of start to wrap up, I think this slide we threw it in here because it really highlights how complicated things are and how much it's evolved over the last few years. Not a long time ago, we were just focusing on your TPA and your contract pharmacy and compliance, and that's just it. Today we're talking about ESP, Beacon, MTF, Truzo, rebates, multiple manufacturer requirements. So that's why we wanted to include this slide. Each platform serves a different purpose. If you need help determining who are you supposed to be using, all of that, we're happy to help you with that as well. So I think the biggest takeaway is that, covered entities, like you don't need to like run out and change everything tomorrow. It's just take your time. Now's the time to start understanding your options, identify, the available resources, what do you have available to you, and thinking through how your organization is going to respond as this just continues to expand. Who's going to submit the claims, reconcile the rebates, what reports do you have? Again, going back to what's your TPA doing? Where are those gaps? So just navigating these changes, it's not the ones that are doing the most today. It's just the ones that are understanding what's coming and building that plan and putting the right resources into place to be proactive and not reactive. Because obviously we don't know exactly what the future holds here, but we know the environment is evolving and kind of what's coming. So the more prepared you are and flexible you can be, is going to benefit you greatly. So.
Okay, kind of on that same theme, how do I know if I am impacted by these changes? So that is definitely a question that we have heard a lot over the last several months and really over the last couple of years as these changes just continue to pour in. So the reality of it is that every covered entity is going to be impacted differently, depends on so many different things like your manufacturer mix, contract pharmacy network, entity-owned pharmacy strategies, your IRA utilization, TPA capabilities, and really just overall your program structure. That's why it's difficult to look at one of these changes and immediately know what it means for you specifically. We found that the most successful organizations, like Lindsay mentioned, are evaluating this now and early on for the future, and kind of trying to figure out where they stand today to determine what changes they may need to make in the future. So we do just want to point out that here at RxTrail, we do offer profitability assessments. What this is a financial and operational review of your entire program to help you better understand how your program is performing currently, identify additional opportunities for improvement, which is usually through things like manufacturer designations and that strategy, contract pharmacy network, referral capture, and just overall 340B profitability. So the goal is just to kind of help you understand where you stand today, and so you can make informed decisions on where you need to adapt and change as these policies continue to evolve. So if you are interested in hearing more about our assessments or want our help with that, we're happy to talk with you after the webinar.
Yes, we would love to. That's actually my favorite part of my job is planning. I'm very type A. So is Bailey. So we're good at that and would love to help you just get the plan in place. We finished a little early, so we have time. Let's see if we have some questions here that we can address. There is one in here. I'll just read it. Is the presentation being recorded and will it be available? The answer is yes to that. There's a couple in here like asking what's the alternative distribution model. Bailey, you're kind of dealing with that with a couple customers. Do you want to speak to that?
Yeah, so alternative distribution model, what we're talking about with that is so some covered entities have decided to implement that as a strategy to kind of overcome manufacturer contract pharmacy restrictions. So what they'll do is purchase the drugs through your hospital account, and then you would have to basically ship those drugs to your contract pharmacy where they'll dispense it. There's a lot that goes into it, a lot of planning and considerations. It depends on your state and what your pharmacy board and like type of licensing is required. So lots of considerations if you are going to do it. The problem that we're seeing now is that with these new manufacturer data requirements, so if they're requiring you to submit all of your medical claims and in-house pharmacy data, that's not going to match up with your purchases if you're purchasing on ADM, because you're purchasing on that hospital account, but you don't technically have those medical claims to back it up because those dispenses are happening at your contract pharmacy instead. So we've seen they're kind of cracking down on this, I think, through some of these data requirements. So that's just another consideration that could make it very difficult to be successful with an ADM, especially as more of those manufacturer restrictions come out. So,
yeah. Well, and I mean, once we see what's going to happen with this Lilly 5-day notice, like, are they truly going to go against the 340B statute and really pull these prices, and what's going to happen? Yeah. So let's see, what else do we have in here? I did see about if you're a clinic that utilizes paper logs as far as uploading for medical claims. So this kind of goes back to what we were just hearing at the grantee conference, with the attorneys and everything that we're talking. Obviously, I'm not an attorney, so take this for what it is. But just them saying, like, are you willing to risk it? Or, you got to weigh the operational burden versus, do you want to be one of those that's going to, basically what they were saying is we need a few people that are going to stand up so that we can start the legal stuff with all of the medical claims. And I guess risk having their pricing pulled. But that's what I'm saying. We're really anxious to see what happens with this 5-day Lilly. I don't know anybody that's using paper logs. So I can't necessarily speak to how you would do that besides getting out of paper logs, which isn't great advice. But yeah, so I don't know. I don't have a good answer for that. Let's see, what else do we have, Bailey? You see anything?
I'm going to answer this one here. So the question is, we have one local independent contract pharmacy managed by Well Partner. Does submitting claims data to ESP and Truzo from this contract pharmacy cover the potential for duplicate discounts on IRA drugs? So kind of the goal, we know that Beacon MFP and manufacturers are utilizing that ESP dispense data to identify claims as 340B or not, and therefore make their decision on if an MFP rebate is approved. So yes, in theory, submitting good claims data to your ESP, well, I don't know about Truzo. I'll say ESP. I don't know that they're using Truzo data because that is a separate company. ESP and Beacon are owned by the same parent company, so I think that's why they really closely work together. But the idea is, yes, you submit good claims data to ESP, and that should help on the MFP rebate side for your contract pharmacy. Again, kind of that's what should happen in theory. We know that that is not always the case, and there are a lot of issues with that process.
Yeah. There's a follow-up to the paper logs. So she said most FQHC use paper logs and don't have scanning software. So, I mean, again, it goes back to do you want to fight it? I guess is like, it's very, I don't have the right answer. I would definitely seek out some legal counsel with that, because I do know there are some loopholes with these manufacturers. I know Lily's calls have been very, why aren't you? Is there a reason why you're not? That could be a very good legitimate reason. So, but having obviously legal present to help address that, I think would be the biggest benefit to you. Let's see. Bailey, do you know much about the ICN? I saw that question in there. If not, we can follow up with her after this call. It's how are CEs identifying the MFP claims with an ICN? Let me go back to that slide too.
Yeah, that is, you can search by that in the Beacon MFP platform is what we were getting at with that. But let's follow up and
okay.
Make sure I can get you more specific details on that.
Okay. Alrighty, I think that was everybody's questions. I didn't see any other ones come through. Obviously, I just want to thank you guys for joining, all the questions that came in advance. Hopefully today's discussion gave you a little bit of a better understanding of kind of what we're seeing in the 340B world right now. And just don't wait until something becomes urgent to start planning for it. That would be my biggest takeaway from today. So as we mentioned, we also received a lot of HRSA audit and compliance questions. So we're going to just dedicate an entire webinar to that alone next month. So just be on the lookout for that. But thank you again for spending part of your day with us. We appreciate your time and your support, and hopefully got some of your questions answered. But please don't hesitate to email myself or Bailey. We would love to help you. So hope you guys have a great afternoon. Bye-bye.
Thank you. Bye.